than you have to do. Amount or complexity of data to be reviewed. This is the piece where we don't always get that many points, because as you can see, we'll usually get a point for ordering or reviewing lab tests with someone. This is why you want to write down reviewed CBC with patient. That was normal, but ferritin was only at 22. That one line, you get this point. If you're reviewing x-rays or CTs or endoscopy reports, you're going to get some more points. If you actually call up another provider while the patient is there and you're discussing records, you're going to get a point. Just the decision to order, where is it? Decision to obtain old records. So if you request medical records, you get a point. If you're reviewing and summarizing old records while the patient is there, that's 2 points. One way with new patients, I always tell my front desk when they schedule, tell them if they have old labs or records, they should bring them with them. Because now I automatically now have records in front of me that I can review while they're there, and I'm going to get myself some more points. So that's how understanding these guidelines starts facilitating your flow so that you can bill at the level that you want to or need to. Someone asks, how do you chart normal findings on the exam? Do you need to say what you found, or can you just say within normal limits? The rules around normal is you can say exactly that. Heart and lungs, RRR, rate, regular, rate and rhythm are regular, or lungs are clear to auscultation, or EE&T exam done, all normal. You can denote the normals without going through every point, but if it's abnormal, you have to specify what was abnormal. So within normal limits works just fine for your normal pieces of exam. When we look at the table of risk, you only have to get the highest level in any one of these columns. So typically, our testing is not what's the highest risk for us, because you'll see very quickly we're usually ordering venipuncture, maybe a chest, that's supposed to be x-ray, not s-ray, or an ultrasound in our kind of primary care practices. So that's always going to be minimal according to conventional medicine. However, when we start talking about our chronically ill patients, 2 or more stable chronic illnesses, an undiagnosed new problem, you fall into the moderate risk really quickly, and you only have to meet one of them here. So even if you're only doing over-the-counter or hydrotherapy, etc., at home, and that's considered low risk, if you're managing multiple stable illnesses, chronic illnesses, then you're obviously already in moderate risk. The reason I like to double check all my med lists is because if you're doing prescription drug management pretty much on any level, and you say, see updated med list, and you're reviewing herbs and drugs and all that stuff, then that is prescription drug management. Depending on what state you're in, you have to decide what you can and can't do. And then that prescription drug management throws me into the moderate risk, which lo and behold correlates over to a 99214. So you're probably already doing a lot of this, and you should be billing it a 214 probably the majority of the time. And we can get to these higher levels occasionally. You know, if I have someone who comes in with ulcerative colitis and they're in the middle of a flare, well, that's a high-risk patient, and it's going to obviously fall into the higher risk. You may have to get them off for imaging and surgery, etc. So then that's going to justify that 215 or that higher coded visit. I'm going to pause. Bob has a comment on normal.
Thank you, Mona. Just to clarify, when you were talking about how it's all right to refer to findings as normal,